Now let's talk about extraperitoneal insufflation. See, when you're trying to introduce the Viris needle and you do not hear the 2-click sound, it even happens with the most expert people that they're not able to appreciate the 2-click sound sometimes in certain circumstances. And it does happen that you're thinking that you're inside the peritoneum but you're not. So in that case, there is a chance of extraperitoneal insufflation. Usually it is not that bad because the moment you see that it's the insufflator readings are not going the way they have to go, and you are perceiving that the liver dullness is still there and it's not gone and so much volume of air has already gone, you stop the flow and you try to see where you've gone wrong. And just in case you understand that, oh my god, this is extraperitoneal insufflation, and you just immediately take it out, you try to through the other port, or you open up the abdomen the way you like it, the way you are skilled, or you call for help, whatever. But usually it doesn't happen. That serious problem usually arises by this. But yes, even subcuticular emphysema has also taken place because of this particular problem. Not exactly subcuticular, but yes, an extraperitoneal crepitus, an extraperitoneal gas collection, and because of that, crepitus and emphysema has also taken place because of this particular complication. But that is again not a very serious complication. In expert hands and semi-skilled surgeon also, they'll be able to pick up that you are not inside the peritoneal cavity, and they'll immediately abandon the procedure and then try through the other route or open up the abdomen. What is more important is the second one, the other one, that is electrosurgical complications. I said that before, I said in the previous lecture. These are very important because right now you are dealing with electrical energy flowing inside the body of human, and these complications are more with monopolar electrosurgical generators than they are compared with bipolar, for the simple reason that in case of monopolar, this current is flowing through the body of the patient. So any loophole in this circuit will cause a problem to the patient. In case of bipolar electrosurgical circuit, the circuit is complete between the two prongs of the bipolar instrument, right? So what happens is that you do not have that much problem as you can have with monopolar current. Why I have written out here in tabular form is because I'm trying to make you understand through these headings which are already there in your textbooks. Had I been taking my lecture, I would have given it in a different way. But since these are the words which are there in your textbook, I'm trying to elaborate them in the way examiners would be expecting from you. Let's start with the first one. Active electrode trauma. See, right from the time you have the electrode in your hand till the time you're done with your work, you are having an active electrical equipment in your hand. And the idea that you have a foot switch which even inadvertently pressed can cause a problem to the patient is a huge risk in itself. Alright, especially the monopolar current. So inadvertent, this is an active electrode which you have in your hand. Any equipment, a laparoscopic equipment that you have in your hand, okay, that is having its tip monopolar current, it's dangerous. So active electrode trauma, I'm talking to anything that this thing might touch in its way to cauterize the particular vessel. It can touch a bowel, it can touch the ureter, it can touch the bladder, it can touch anywhere but the vessel that you. So this is a very important, this is right there in front of your eyes. You know that this is an injury which can happen at any point in time, and it's nobody's fault. It's just the fact that you're working at millimeters distance inside the abdomen, and your hand movement even 1 centimeter can cause a problem inside the patient. So what is important here in this case is that you should know that all the time you have a live wire literally in your hand and you're putting it inside the abdomen of the patient. So you have to be very careful at your hand movements. So that was about active electrode trauma, absolutely point blank. Nobody can, mess up this particular thing. It's right there. The other thing is worth having a thought on, and this is current diversion. Actually, the word they have used is not very much self-explanatory, but when I speak remote injury, you will be able to understand it better. You know, direct injury, the injury that is there in front of your eyes, direct injury, you were trying to coagulate the vessel, but you in fact ended up coagulating the ureter, or it touched the ureter. You put your foot on the thing and the current is flowing through the through the artery, and it somehow your hand got, you know, shifted and it touched the bladder. Uterine artery is very close to the bladder, very close to the ureter. So your hand moved and this is direct injury. Remote injury is something totally different and a very important complication of monopolar current. The idea is the simple thing that you are putting too much energy at one particular place, it dissipates. It dissipates and it usually finds the area of least resistance, and the area of least resistance is a point which is the weakest in the link. You're trying to coagulate a thick vessel, alright? And that thick vessel is somewhere very close to it, your fallopian tube is hanging. Okay? Fallopian tube's tip is touching that place which is quite close in proximity to the area that you are coagulating. You're giving a lot of current in that area. The current has tried to seep inside, more than that it has gone laterally, and now it has burnt the fallopian tube, and the fallopian tube got burnt at a place which is not there in your direct visualization. That is remote injury because of current diversion, seen more in your monopolar as compared to bipolar. So the idea behind these things is to give energy less for lesser amount of time. So if you're putting 30 to 40 watts, choose 30 watts and give it for lesser amount of time. Press it for tit. Try to make it as less as possible. Give it lesser time and lesser energy so that the current diversion does not take place. Chance of remote injury is negligible. Then we talk about insulation defects. Very, very common, very prominent, can happen at any point in time. Insulation defects, if you're using a monopolar current and there is an insulation defect at any place, the current will jump to that particular area which is in contact with the bowel, with the skin, with the mesentery, with peritoneum, with anything that comes in its way. So it will jump and it will cause injury in that particular place. So instead of current flowing through the place that you're trying to coagulate, the other thing is also getting burnt. Very simple, very straightforward. Now there is something called as direct coupling. Now what happens in case of open surgeries is you hold a particular vessel in your artery forceps and you put the cautery there. That's monopolar cautery that you're using in your open surgeries most of the time. So you hold the whatever vessel in between the artery forceps and you put your cautery here. This is direct coupling. Something which is there in front of your eyes, one metal is touching the other metal. This one is an active metal and it is causing the current to flow through that metal, is called direct coupling. And then comes capacitive coupling. Capacitive coupling usually happens when you're using mixed instruments. You have introduced the cannula, a metal cannula, and you have introduced your monopolar instrument inside it. Now, if there is an insulation failure inside, the current will flow through that cannula to the skin totally, in totality. So the area around that is conducting the current completely in a wider area. See, the idea of having lesser injury is the fact that more area is involved. If more area is involved, the dissipation of current will take place in a bigger magnitude and the injury will be negligible. But if smaller area is involved, every bit of electrons are flowing through that energy and it will cause a major devastation rather than causing a mild effect. So if there is a insulation in the cannula that you're using, you were using a metal cannula, but there is also a plastic sheath around it. And now if there is a current flowing, it is not going to flow through the body of the patient. It is going to flow only inside the cannula, and the cannula now has become what the monopolar instrument was. A beautiful diagram is given in Novax for this to elaborate on this particular aspect, and you'll be able to understand it very well through that particular thing. So entire cannula now touches the bowel, mesentery, whatever. It is giving the same effect but on a very small pinpoint. So with that, I finished the electrosurgical complications. I'll be back with hemorrhagic complications because even they have to be spoken in points.